This is episode 85 of the Psychcast by MDedge, where we bring you interviews with leaders in the field of psychiatry, masterclass lectures, and relevant inspiration, straight to your ears with new episodes dropping on Wednesdays. I'm the voice of MDedge Podcasts, Nick Andrews. Coming up later, the editor-in-chief of MDedge Psychiatry, Dr. Lorenzo Norris, welcomes Dr. Kent Kiehl for a conversation on psychopaths. And now, this week in psychiatry. New research presents a complex portrait of suicidal behavior in U.S. teenagers over the last few decades. From 1991 to 2017, the overall rates of suicidal ideation and plans dipped. However, the rate of suicide attempts grew among black adolescents. In the report published in Pediatrics, white young people had historically higher rates of suicide attempts compared with their black counterparts. However, this study provides some evidence to the contrary. The study was led by Dr. Michael A. Lindsay, who is executive director of the McSilver Institute for Poverty Policy and Research at NYU. He and his colleagues point out that suicide is the second leading cause of death in the U.S. for adolescents between 12 and 17 years old. In the study, researchers analyzed data from the Youth Risk Behavior Survey. They examined just under 200,000 teens. During the study period, the weighted overall prevalence of rates of suicidal ideation, planning, attempt, and injury due to attempt were 19%, 15%, 8%, and 3%, respectively. They write that their findings reveal that over that span of time, almost 1 in 5 adolescents are thinking about suicide. The researchers also found that 1 in 10 of these patients has a suicide plan. They noted that these findings are troubling because attempts are the most prominent risk factor associated with suicide death, and that the findings regarding the rising rates of suicide attempts in black youth may be related to the documented disparities in mental health treatment and common social etiological factors disproportionately experienced by black youth. In an accompanying editorial, Dr. Benjamin N. Shane mentioned a seemingly counterintuitive fact. Black teens still have lower rates of suicide than white teens, despite the greater, long-standing difficulties encountered by black adolescents. This includes disparities in mental health and disproportionately higher stressors, racial discrimination, and childhood abuse and neglect, as well as other adverse experiences such as poverty. You can read the complete report as well as the accompanying editorial at mdedge.com/psychiatry, and a link to that is, of course, in the show notes. Coming up next, MDedge Psychiatry Editor-in-Chief Dr. Lorenzo Norris welcomes Dr. Kent Kiehl to talk about psychopaths. Welcome back to the Psychcast. I am Nick Andrews. It's time now for the interview portion of the episode. The guest this week is Dr. Kent Kiehl. Dr. Kiehl is Executive Science Officer and Director, Mobile Imaging Core and Clinical Cognitive Neuroscience Professor of Translational Neuroscience with the Mind Research Network. He is also Professor of Psychiatry and Neuroscience and Law at the University of New Mexico. You can learn more about Dr. Kiehl, including biographical information, in the show notes. The show notes this week include an outline of the conversation with relevant references to the topics discussed. Okay, let's get to it. Please welcome Dr. Lorenzo Norris and Dr. Kent Kiehl.
My name is Kent Kiehl. I'm a professor of psychology, neuroscience, and law at the University of New Mexico. I also help codirect a nonprofit mental health research institute, which is known as the Mind Research Network, also located in Albuquerque, New Mexico. And I also help run a little for-profit company that teaches attorneys how to do better science, and that's called Mindset. And Mindset is kind of designed to help attorneys interpret and understand all of the different neuroscience work that we do and others do in mental health and brain injury, personality traits, etc.
This is Dr. Lorenzo Norris, Editor-in-Chief of MDedge Psychiatry. I want to welcome you to today's MDedge Psychcast, and we are very, very, very pleased to have with us today Dr. Kiehl. Dr. Kiehl, welcome to the Psychcast.
Thank you very much for having me.
Okay. So, Dr. Kiehl, given your work and your writing, one of the things that I've been very interested in is to get your perspective, or even for you to give us, if you will, your take or a walkthrough on the current state of the art in the neuroscience of understanding forensic patients. I think this is something that a lot of us aren't up on the literature. We don't necessarily have a clear understanding of it, and I think it could certainly help illuminate how we actually approach forensic patients or violent patients for that matter. So please go right ahead, Dr. Kiehl.
Sure. Well, we've been working with, I really started this type of research in, the early 90s, and the focus of my team's work is to use non-invasive brain imaging techniques, particularly, EEG techniques, but most recently, MRI-based techniques. So we have actually two now, as of today, mobile MRI units that we deploy into various prison settings, from juvenile correctional to adult correctional for both men and women. We've also worked in forensic psychiatric patients. We also work in, civilly committed sex offender clients. And so we basically, if you've gotten yourself in trouble, we've been interested in trying to use these techniques to help understand you. And so that when you say forensic patients, we could talk about all of those different populations. But when we talk about it in terms of like legal context or legal settings, then I think brain imaging most commonly comes into play in capital sentencing in patients that might have, committed a homicide and they're being evaluated for amenability stuff or not guilty by reason of insanity, and all the way up and through to, just plain mitigation-related questions. And MRI scans are becoming, if they weren't already, at least in the last 5 years, they're now ubiquitous. I mean, if you're charged with a capital crime, I think most attorneys recognize that the MRI of people who commit these types of crimes is often quite different. We've had cases that have been as simple as, a frontotemporal dementia diagnosis that would have never been measured with standards. You have to diagnose that condition with the MRI. There's no other measurements of psychological testing that actually gives you a diagnostic test for it. And this individual who killed a couple of people and then got the scan done that showed that he had, the behavioral variant of frontotemporal dementia, he was sent to a mental hospital, state mental hospital, rather than being put on death row. And that's the kind of the clearest, simplest example of neuroscience and the law, where without the MRI scan, he'd be degrading or, quickly in a solitary confinement in a facility had that scan not been done. And there are many cases where men or, or individuals who've, mostly men, of course, have committed these types of crimes, have something very straightforwardly neurologically different or abnormal, from cysts to tumors to old head injuries, that can be very persuasive and valuable information for their attorneys to utilize in their defense. And often prosecutors ask for these types of pieces of information as well, because, if the defense is arguing that they have old head injuries or other types of problems, the prosecution often can say, well, show us the MRI data, and if it's really evident, then we might decide to plead out to a sentence that you'll be favorable for your client. And so we tend to see that the MRI data can really be persuasive in those actual forensic cases. And then you can get into situations where there might be controversy about the psychiatric diagnosis. So does the patient have do they have a form of schizophrenia, or do they have a form of psychosis or not? And often defense attorneys might think that their client does have psychosis, and the prosecution might say, no, they don't, because if they do have a mental illness like schizophrenia, then that might really change the trajectory of the criminal proceedings. And this harkens back to the first time neuroscience was used in support of psychiatric diagnoses, was the case of Hinckley. So when Hinckley shot President Reagan in was 81, if I remember correctly.
Yes. I believe so.
So in that case, there was debate about whether or not Hinckley suffered from a mental illness or not. So one psychiatrist was saying that he did have a mental illness for the defense, and another psychiatrist was saying, I don't think he does, for the prosecution. And MRI scans were done, I think it was MRI and or CT, and they showed quite enlarged ventricles in Hinckley, and a lot of cortical atrophy that was, at the time, present in about 45% of patients with schizophrenia, but only about 4% of age-matched people would have that kind of a profile. So the information that the brain imaging provided was more consistent with the diagnosis of schizophrenia than it was not. And of course, we all know now that he got a not guilty by reason of insanity verdict, and he was sent to St. Elizabeth's Hospital. And every resident who interviewed him there over the next 40 years has said that he has, some form of psychosis, and it's meandered and changed over the years, I think. But Hinckley's actually now been released to the custody of his parents and is in their farm in Virginia, at least the last time I looked in on that case. But the point is that the MRI data was useful to help achieve, it had value in the proceedings. And today we're seeing just enormous growth in attorneys' use of brain imaging measures to help confirm the presence or absence of a psychiatric, diagnosis. So in my life, we designed and developed a whole series of MRI-based technologies, from structural to diffusion through, which is white matter mapping, through brain network analysis using functional MRI, to help differentiate if a patient has, schizophrenia or psychotic bipolar disorder or some form of depressive psychosis. And we did that to try to help inform, first episode psychosis, so you could get better, more accurate treatment. And as we were developing all of this and publishing all of these tests, and even getting better with machine learning to getting, individual level classification rates, sometimes as high as 80, 90%, all of a sudden attorneys start calling and saying, well, would this help me make my argument? And I'm like, well, sure, of course it would. And I said, and so it's been used in a couple of cases because it can help an attorney understand first if their client really does have a mental illness, and they might get different conflicting opinions depending sometimes on who they talk to, and also how their client sometimes presents. So sometimes you can talk to a patient for a couple of hours in the morning and they seem completely fine, and then you get them when they're tired or they're exasperated and they might have a little more stress at the end of the day, and they all of a sudden start to precipitate, paranoid ideation and other types of things that you are more clearly associated with psychotic features. But the MRI scan can be done at any point, and if we are looking at a trait-specific problem or a serious mental illness, it's very sensitive to that. And the modern algorithms that we use are very good at being able to actually help achieve high classification rates from the brain imaging data alone. And so I field calls, pretty much a couple every week about attorneys asking for questions or issues about their particular case or client. And more, it's not just on the criminal side, but on the civil side. Hi, my client has a head injury, and can you help me understand the severity of that head injury using quantitative methods? And sure, we can. There's lots of stuff that we can do to help give a better answer or some more information. It's not like a perfect pill every time, but we can often say that there is huge measurable differences in the white matter or injury, and then many other times you might say, well, there isn't anything that we can see that's different or really abnormal. And so in a sense, MRI is kind of like another version of a neuropsychological test. It's another way that you can make comparisons of information, in this case brain data, to a database of healthy people and say that this is different or abnormal in these areas. And then you go about providing an interpretation just like you would in a neuropsych test, that this is what we think is wrong or is different. And so we're seeing that's becoming far more popular. But
No, please go ahead, Dr. Kiehl.
Well, I was going to say that in the regular prisons, trying to understand and things like psychopathic traits and future violence risk and prediction of who should get bail or not. I mean, these types of questions are very hot topics right now in criminal justice settings, and we keep publishing studies showing that brain scans will predict future, antisocial behavior. They do help produce, variables that are associated with risky behaviors. And we can help predict things like substance abuse relapse and predict, risk for these types of things. And so I'll give you an example of one of my favorite papers that we've done in the last few years. So age is one of the best predictors of antisocial behavior, of course. So we all know that antisocial behavior peaks, in your late adolescence, early adulthood, and then it wanes over the course of the rest of your life. And it's usually pretty good for most of us. It's a pretty good dip that just drops right off, and other than the occasional speeding ticket, you don't do that many antisocial things after you're, 30 or 40 years old. So age in that equation, if you take a 25-year-old man and compare him to a 50-year-old, it's a rough doubling or even almost tripling of risk. That is, the younger man is much more likely, just because he's younger, to be antisocial in the future than the older man. So what we but we all know 25-year-olds, some of whom are, good drinking buddies and always fun and exciting to go out with, but we would refer to them as maybe a little more immature than our friends who are now professionals and don't do anything that would be construed as as immature. But from an from the algorithm's perspective, a risk algorithm, 25 date of birth is like from your age is the only number that it has. But we've shown, and now many other people have also shown too, that there's variation in there, what we call brain age, that we can estimate using the MRI that might have a lot of predictive utility. So I think one of the first studies showed that if you're aging faster than, so you're 70 years old, but your brain actually is computed to be 75, that is, it looks older compared to a normative database, the difference in your aging profile predicts your cognitive performance. So if you look like you're 75, even though you're 70, you look like you're 75, and that's 5 points lower on your cognitive score, the brain data will predict that. So if your brain age comes up as being estimated as older, the amount of variance is explained by your cognitive decline. And so what we did in our analysis is we took 1,000 inmates that we studied. I think it was 1,300 originally, and we threw the MRI data into an algorithm called independent component analysis. It's an algorithm that kind of carves the different networks of the brain into its joints. So then we have 30 different components of your brain that we feed into a machine learning algorithm, and we say, predict their age. And so then it goes in and it finds out which ones predict their age, and it does that really well. And then you say, of those components that predict age, tell me if any of them predict reoffending. And we followed up in a new sample, and it turns out that there are two regions of your brain, two components, both in the anterior temporal lobe and the orbitofrontal cortex, that if you looked younger than your chronological age, that accounted for more variance in the risk equation than did your chronological age. So in a sense, your brain age of those specific regions predicted reoffending more accurately than did you just using your date of birth. And so that's where the MRI data might have a lot of value, is that it is able to kind of estimate brain maturation, which by proxy we were using your date of birth to do before, but the brain age data provides more information, more accurate information about that construct of maturation. And so it also gives us circuits that we can now target for intervention, because we know that if you're older, if your brain's age, or you can develop them or exercise them, or however we can figure out how to update or make them feel better, or make them grow, if you will, because that really looks like they're just immature. So that it's not like they can't be plastic and change. If we could find a technology that did that, be it medicine, psychiatric medicines, or cognitive-based therapies, or maybe stimulation-based technologies like transcranial magnetic stimulation, et cetera, that if we could generate, and change those areas, then maybe that'll promote desistance from crime. And that's what's just really exciting, is that that the brain data gives us a lot of information about where and how we might be able to do that.
All right, so let me just, wow, a lot of information. Very interesting, and I would dare say exciting. And I have a ton of questions, but one of the first questions, I'm like, how did you consent 1,000 inmates? That's something separate. That's amazing, just to get all of that done. But the other thing is, if I heard you correctly, Dr. Kiehl, you scanned the inmates, 30 regions. You looked at those regions. You put it into an algorithm with deep machine learning, and the algorithm got very good at predicting the age of those brains, if you will, or the patients. But then you started to ask the algorithm what actually will predict reoffending. And there were two regions in particular, if I heard you, the orbitofrontal cortex, and I want to say the anterior temporal, if I heard you correctly.
That's all correct.
That is fascinating, because, again, I won't break out my neuroanatomy or whatever, but when I'm thinking about orbitofrontal cortex, I'm thinking about decision-making. I mean,
absolutely.
And if that is astounding. If we actually can routinely show that the area involved in decision-making is, in terms of chronological age or whatnot, is not where it should be in offenders, and that predicts reoffending. I think that is, I just want to make sure I heard you correctly, because that is really, really, really interesting. And it makes me wonder, partly, I mean, some people have already made this argument, why aren't we at least starting to include, if you will, imaging data in our diagnostic scheme, right? And I'm talking about the DSM here, because this at least you can start to. It gives us something to, I think, a bit better to improve on, more so than our current system in terms of like basically consensus, symptom-based things. But I find that fascinating, so I just throw that back to you.
Sure. Well, so the number of great questions in there. The first thing I'd say, we've actually consented over 5,000 inmates in the last 10 years. And so, inmates are just like undergraduates in a sense. They really enjoy doing research. And so we've been fortunate to work with both the New Mexico Department of Corrections, the Wisconsin Department of Corrections, and allow the inmates an opportunity to participate in these types of research studies. But we also have a lot of federally funded studies doing treatment. And so we've been able to provide treatment to offenders that they wouldn't otherwise get because we're studying things like how their brains change with the treatment. And so there's a great collaboration between these Department of Corrections and on our academic side to bring good treatment to the inmates, but also to be able to get great research data to help us improve the lives of and the treatments that are available for these individuals. Within the brain age work, you summarized it very accurately. So within the range of inmates in a prison, so within the 1,000 inmates, we were then able to say that those that look younger than their chronological age in those areas, those are higher risk to reoffend than the other inmates who look older. So that's what the algorithm was basically able to help us do. And you're absolutely right. Orbitofrontal cortex is obviously a well-known region of the brain that is critical for decision making. So we know that if you get lesions there, you actually get what's called like an acquired sociopathic-like syndrome or acquired pseudo-psychopathic syndrome, written by Damasio and Trinell and all sorts of neuropsychologists have written about these guys for years. And those types of patients tend to make decisions that could get them in economic problems, or they could get them into sometimes antisocial behavior. But that's definitely a very important reason of the brain for decision making. And what's fun about the algorithms and the work that we do is that the algorithm doesn't know what that area of the brain does. You know what I mean? Like we ask it what predicts, and it says, here's the ones that predict. Of the 30 you gave me, these are the ones that are predicting this outcome variable. But it has no idea that those are the areas that we all predicted. That's what. Yeah,
that was what was so exciting about it. I mean, when I would think about the brain, I would think if I had to pick certain areas, that certainly would have been one of them, and the algorithm predicted it. So I was like, whoa, that's wow.
There are occasionally, one of the most enjoyable things about being a professor is having your students. You occasionally hear these exciting screams, when they do an analysis and it comes back and you're like, it's exactly as you would have predicted, but what's the algorithm just doesn't. These new machine learning algorithms that everyone has been implementing, and we continue to develop them with a lot of collaborators, they're really pretty amazing in the things that they can do, and then the math that we're able to enjoy today that we didn't have 20 years ago. And it just makes the science a lot more accepted and a lot more readily, implementable because of its robustness and the types of science that we do. Because we find, and definitely I've found as I've gotten older, is that there's people that really want to consume your science. They really want to use it to help achieve outcomes for the betterment of society. They don't want to wait, a long period of time after the paper comes out. They're like, can I use this? Can I use this for my clients? Can I use this to help me make a better decision? And judges are the ones that actually ask about this the most, because they often have really imperfect data in front of them. They have one attorney telling them that this guy should be released early or not, and another guy saying, no, we don't want to do that. And the judge is like, well, is there any evidence-based algorithm or data that you could give me that could tell me that I should release them with these provisions, like, have to be, can't go to a bar, can't go to have to have a GPS bracelet or don't, or should I not release them because maybe they need more treatment or whatever. And these decisions are expensive, and these decisions have huge implications for society and the individual, of course. And I hope that the neuroscience research that we're doing will be able to help improve those types of decisions and to help make better treatment decisions for individuals.
And that is one of the things that I wanted you to touch upon next. I want to hear more about what you all are doing in the realm of treatment, because it's really interesting to hear about just in terms of imaging and things that aid our understanding and diagnosis of these conditions. That there are, if you will, we identify at this point in time from your research, and we can see that there are identifiable patterns that can aid us in conceptualizing how we can assist and help our patients basically heal, because otherwise than that, and I'll just speak from kind of my mindset of it, without that, I think that at times there can be a tendency either to, one, there's not anything really to help you start to understand or guide treatment, but also there can be a tendency to view people as objects, that I don't understand them, or I'm this or that, or evil or something of that nature. But I kind of think a bit of the beauty of what I'm hearing just in terms of how you're describing this is that the science is helping people in society devise treatment plans so that we can actually work with people, so that we can actually, not dehumanize them, but say, okay, this is what's happening. Let's all come together to figure out what can we do in an evidence-based way. So again, that's kind of what I'm feeling as you're talking. So, and that is a very, very, very good thing. So please tell us about the treatments.
Sure. So it's absolutely right. I mean, the main goal of the entire career is to develop prevention. It's to prevent these types of crimes that these individuals often commit from ever happening, because I think that's what everybody wants on all sides.
Absolutely.
So in my life, there's no more vilified, construct, if you will, than psychopathic individuals or psychopaths. And, we now study these traits all the way down to, the emergence of them as early as kids 5 or 6 or 7. And everyone wants to know, how would you treat them? If you can measure this accurately and you can assess lack of empathy, guilt, and remorse, and you can say that this child is at risk or this adolescent is at risk, what would you do to try to intervene? And there's a classic dogma in the world, if you will, that they're just not treatable, that you should just lock them up and you should just put them away. And this was the 10 years ago, this was the state of the art, state of the world, and in many places it still is. But a group in Wisconsin were charged by the state legislature with developing a treatment program for maximum security, adjudicated boys who had been convicted of multiple felonies, but were also not manageable at the other states' facilities. So they carved out a piece of the budget from the Department of Corrections through a state legislative process and sent it to the mental health facility, the Mendota Mental Health facility in Madison, Wisconsin, and they said, here, we're going to now send you 50 boys a year that we can't manage anywhere else, and we need you to try to develop a treatment program. And they said, well, okay, no one's ever successfully implemented a program for this high-risk category of boys, but we can manage people like Ed Gein. That was like the motivation for Hannibal Lecter, right? He was a patient at that institute for many years. If we can keep him from eating people and, all puns aside, if we can help manage him and his violent behavior, maybe we can really do something for the boys. So they started from scratch. It's a year-long program, or longer. It's all contingency management-based, so positive reinforcement, because we know these high-risk youth often don't respond to things like punishment. So you use positive reinforcement, contingency management profiles. You have an MST component, so multi-systemic family therapy component, where the families are brought in to try to help develop a plan for when the child is back going to be released into the family, so that you don't just throw them back there without any thinking. And there's dozens of other different stages. And I wrote about this in my book, The Psychopath Whisperer. But this program has shown that in boys that get like 10 months minimum of this treatment on board before they're discharged, that there's a 50% reduction in the numbers of violent crimes that they commit compared to boys in the system as normal. And it's not a true randomized design, but you're taking boys that the state has said they're so maladjusted we can't manage them. Here you go, do your best. And so they take those high-risk kids, and whereas normally like 60% of them will commit a violent crime in 3 to 5 years. That was the data they had for the previous generation. Now they've only getting like 20% of them committing a violent crime in 3 years after release. And what's really amazing is that the 200 boys that they followed up, and I think it was 4 years now, the 200 boys that were in the control group that didn't get this type of treatment but were otherwise pretty high-risk boys, they killed 16 people in that 4-year period. And the boys that didn't that got the treatment, they didn't kill anyone. They still had some violent crime, but there were no deaths. And so that, when you think about progress in my field, that in these high-risk kids, these high-risk young adults, and you can show that you can reduce the outcomes that dramatically with just the first iteration of a treatment program that you designed from scratch.
Wow.
Well, that's just staggering, right? So I go around the world and present this data that they've published, and now we've been working with them research-wise for the last 5 years, studying the brains of these boys as they go through treatment to try to understand what's the plasticity that is changing in their brain, and then to help. The goal is, of course, to show that even if you take the highest risk kids in the state, that you can change them and they can go be more, valued contributors to society. They cannot come back to crime. And the thing that's staggering politically about this, just from a political perspective, really, is it's financially in the state's best interest to do this. Because for every $10,000 the state of Wisconsin invested in this treatment program, it reduced future incarceration costs by over $70,000. So that's a 7-to-1 return on your investment, which is like 10 times what the S&P 500 was getting in the same time window. So they and the state. This is fascinating. The state required they publish these results, paid for a psychologist to be on board there to publish whatever the results were, and he did these economic analyses that showed that it was really viable for them. So now we know that the state of Georgia has adopted a similar program. They're trying to implement an identical program there. They've had conversations with other states about trying to adopt similar programming. And I think when you commit to it from a state from the ground up, it is, in my understanding, and I study these things, this is by far the most advanced, most successful, evidence-based, peer-reviewed, published studies that in the world. And so if there's anything that comes from doing a podcast like this, to be honest, it would be that someone would call me up and say, like, how could my state do this? How could you help me get my state to do this or something? And I'm happy to come give presentations to state legislatures, to people about this type of program. But it really does take buy-in at the highest levels of government, like a governor level or a cabinet level, and then for them just to say, we're going to do this as an institution. Because, I go around the world lecturing to this, and I've been in places where, we've studied these kids who are in these high-risk categories. And I'm not talking about kids who are going to go into juvie detention for 30 days and then never go back because they're scared. They're just adolescent limited. And most kids are like that. 90% of kids are going to age out of these types of behaviors. But when you're working with the really high risk, that's what I study, these kids that are on what is the concern is they're called the life course persistent trajectories. Temi Moffat's work in Abkhazia talking about kids and how do you identify this cohort that are likely to be ending up in jail. And so that's usually going to be like state level custody, high security, have already done something really bad, maybe a couple of times. And those kids, most of them are going to end up in adult facilities if there's not great intervention. And Wisconsin has definitely provided the best evidence-based program that I know of. And so I was so excited about this when they started publishing their work that I just called them up and said, can I collaborate with you guys? Can I do anything to help with this? And they were really interested in studying the kids' brains and studying like how they might be changing or how could you use the brain data to reinform treatment progress. So for example, kids go through, you might have kids that go through in 12 months and half the kids might show full change, but another half might need 14 months instead of 12, or they might need 18 months. And so can we use the MRI to assess, the impact that they're changing? Because maybe some kids only need 6 months, and then they're getting they don't need more treatment. They're going to have the effect. And so can the MRI help us? And those are some of the really tough scientific questions that we've been working with lately, is to try to understand that.
Well, Dr. Kiehl, thank you so very much for sharing all of that. I mean, a lot of things went through my head as you were talking. One thing that just struck me in terms of the science and really how the science was informing the treatment, this treatment in terms of, if you will, an emphasis on one treatment as well as development. I would also say time. And you said a word that I thought was very important. They don't, our patients that we're working with, our fellow people, if you will, this group, they're not responding to punishment. And I thought that was like such a very key point. That in the time, I would be curious because you go around the world. I would be very curious if the treatment that you are utilizing right now, if the brains, if you will, or the effects of this, when the children come out after the treatment, if their brains in some way look very similar to the brains of, if you will, citizens in Norway who have undergone in their prison system, and I believe Norway has the lowest recidivism rate in the world, but my understanding is their prison system, from what I know of it, is quite different, but it has many of the elements that you're talking about in terms of an emphasis on development, no punishment. I believe that, their guards are trained a completely different way. They don't wear guns or utilize guns. So when you were talking about that, it was just such an incredible intersection, if you will, of science, what intuitively, as you think about it, yes, this does make sense. We have to work with people so that they develop personally and their brains so that they can be to a different place. And as
Absolutely.
you were talking about this, it becomes, when you think about the brains and the development, now it starts to become rather clear that repeated incarceration, as well as going from prison back into an environment that could probably result in more, if you will, negative brain changes, whether that is an environment where there are food deserts, whether there's an environment where there is, if you will, social injustice. This is where a number of those social determinants of health come in. I'm blanking on our professor's name who's just on here. He's going to kill me. He's from the University of Toronto. But we had a very, very good discussion in regards to the immune system and inflammation and how all of that is starting to play a role. We're starting to see the links with that in mental health. So all of these threads, if you will, are starting to connect. But the biggest thing is what you said. I mean, how do we use this science to act now for treatment? And it doesn't have to be, we don't have to go to the moon to get it. We can start right now, even though I do agree with Saul Levin, we are going to need a bit of a moonshot. But stuff like this kind of information, I think that's kind of part of that moonshot in terms of getting us a bit of a paradigm shift in terms of how we view folks. So, yeah, I mean, really, 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 really blown away with it. And this would be the other thing, I would say. Because you're talking about a return. Yeah, prevention, I agree with you. I think that we really need to focus on prevention. And I also think that even if the investment is more than one might think at the start, it is worth it for what, just in terms of human suffering, it's going to save you, but also it is going to make financial sense. I mean, given my role, I understand, in terms of we do have to think about, people do, for better or worse, think about finances, but it's a win-win-win from a number of reasons. And I personally have a particular interest in this because people who have seen my picture or whatnot, look, I'm a black male. So I'm part of a group that is disproportionately in the prison system. So this really does, I'm really interested as well as passionate about this because it is giving people, if you will, potentially a different way or different alternative in ways in which they can live their lives, basically.
I mean, yeah, I cannot.
Please go ahead, Dr.
Kiehl. No, you said you had about a dozen great points in there that I would have completely, echoed. And places like Norway are actually closing down a lot of their prisons because they have been able to achieve such a low rate of reoffending. And they also decriminalize drugs and other types of things that reduce. They give them treatment centers. They provide treatment-related resources, community-based resources, rather than locked-up types of resources. And that has a tremendous shift because then even if you have to have a substance use problem, if you're able to live in the community and live there, you can often still have a job and have other types of, positive. So there's a lot of things that we can learn from, international, positive outcomes that have occurred. And I'm quite familiar with Norway's, incarceration, programs in terms of trying to help them with the positive reinforcement. And they teach them how to cook, how to make food, they do all these living skills that then the person is prepared to go out and isn't going to. It's just much more of an advanced way of doing it. And what's staggering is that it's economically the best thing to do because when you do it well, when you implement this well, they don't come back, and then that's the cost savings. But that becomes a politically interesting perspective because often, moving the pie around, so to speak, of tax dollars, it is often can be a struggle. But no one wants to see their prison shut down in their county, because they rely on that. But if in if the money still is there, but it's shifted towards rehabilitative services and other types of things, then we should be training people so that they can do both of those things. But I'm no expert in correctional implementation and those types of things. I just know that I'm a big advocate for evidence-based programs that really can change the way the world views individuals that we would otherwise just consider high risk and just incarcerate them. And it's just so exciting that we have programs like this, in this one in particular, but also other ones that are being developed that can really change people's minds and hope to get better treatment and better outcomes for everyone. And you're absolutely right again about the societal benefits. I mean, the absence of homicides, the absence of and reduction in violent crime, I think is what everyone wants. And so it's just a great. We need help doing it. We need help. Yeah.
Right. When do you think? I agree. I mean, given that where we're at now with the science and functional MRIs and all the different methods, when do you think we're actually going to get to a point to where we're going to have routine neuroimaging of patients with mental health conditions? Because right now it doesn't happen.
You're right, and I think that that's a great question. I think that if in terms of routine mental health care, getting an MRI scan, I think that's pretty rare. We've even offered it to our local facilities here that our institute would offer MRI scans, and they've often been concerned about it because what you have is also a change in if I can be diagnosed with an MRI scan rather than having to do a clinical interview, well then I just trained for 5 years on how to do clinical interviews, so those people are a little resistant to the idea that they might be supplanted by a new technology that's going to actually. So you run into these types of issues and questions. I actually think there's a lot of great data that would show, that we can do, very good prediction. And I'll give you a couple of examples. So we have a place in New Orleans, just outside of New Orleans, that we've been invited to come down there and scan consecutive psychiatric admissions. And the goal is going to be able to say, does the brain data predict better than the average clinical, score? So can we predict the type of illness this person has or medicine they should be on or risk behavior that they might commit? And we're going to do that for like 4 months and try to scan every single person that comes in, 400 or 500. And then we also have the same opportunity at Penetanguishene, which is now called Waypoint in Canada. We went up there last year and scanned 100 patients, and that's the largest forensic psychiatric facility, I think, in Canada. So we would like to go up there with the mobile MRI and offer a chance to test this. And so I've always wanted to go to like Atascadero in California. 5,000 patients, I think, are there, and wow. Scan all of those patients and then ask the question, does it really have incremental value? Can I help them make better decisions with decoding the MRI data such that they may want to actually invest in having it done? And so I think that there's still a lot of work to be done in terms of it's being used in your everyday mental health case. But we also get parents and people calling us all the time asking, my child, something's wrong with my child. Will a scan help me understand that? And I say, well, in some cases, sure, it might help, especially if we if there's something overtly neurologically wrong, but you can learn a lot from the quantitative analyses that we can do today. And so sometimes those parents do bring their kids here for a scan to an assessment to try to see if we can help provide them with a good platform that they could then go back and implement a better treatment where they're from. And so I think that in our lifetime we're going to see MRI scans being used far more commonly in everyday mental health. In forensic, I think it's probably going to get there more quickly because it's expensive to not take good care, to not manage them well. So it's cost effective. If the data has value that helps provide better outcomes, then it's more likely to be adopted in a forensic psychiatric environment than it would be in a state regular, outpatient clinic, for example. So, and then of course there's a whole civil side which everyone always forgets about, and there I would say we're seeing nonlinear growth in the request to help with assessment of does my client have a disability? Does it have a head injury? Do they have something that you can tell me that can help me make a better argument for the client? And in that case, it's often today the answer is yes. There's a lot of cases that can benefit from having these types of analyses done on their client's brain data, and it does achieve good outcomes for them. So a car accident victim or a disability claim, and helping to quantify these types of injuries is becoming more and more routine. And we do 300 or 400 of those cases a year right now. And so I think that it's going to be far more common, and it's going to be driven by what's interesting to me is that the civil system has different economic levers than does the mental health system. So the civil system, is going to, because it gets there's value in it for them, they're going to consume it first, and then you're going to see it start to matriculate into these other, systems that are where there's a little less influence of it right now. So it does, yeah.
Well, Dr. Kiehl, I just got to ask you a couple more questions because I wanted to touch base on something that you just said. I firmly, that idea of neuroimaging replacing a clinician or a physician or any other kind of technology modality for that matter, I think we have to, as a group, not just psychiatrists, but health professionals, psychologists, social workers, we have to attack that notion. Because to me, that gets into the being in the business, if you will, of diagnosing disease, which is not, we should be about prevention, development, and growth. And in that context, if you're about that in treatment, then technology can only aid. Why would I not want that? Why would I not want the most accurate diagnosis? Because I have yet, even though there are actually some of our colleagues have shown that patients are responding a little bit better to computer avatars for an interventionist than people, but that's a separate story. But I've yet to see one of my patients prefer to talk to an MRI machine than me. And no matter what the diagnosis is, we still have to, if you will, we absolutely have to treat, and we need effective treatments. And I think we want to start looking at modalities, even if people still, because I know I'm going to get pushback from folks, and they're going to say, like, the imaging isn't there, the genetics isn't there, this isn't there. But we have to start pushing ourselves to utilize these things because I do believe that they can help patients. And I don't think that they're necessarily, I do believe that there's a potential for them to help patients. You should never say do no harm, but we have to start pushing ourselves. Now, one other question I did want to ask you, and it comes from a colleague of mine who is a former behavioral health director and who's followed your work. So if it's okay if I just ask you this question. Okay?
Sure.
You've already kind of touched on it, but I do want to ask the question directly. Just wanted to know if you think eventually we can figure out how to heal the brain of those with sociopathy and what the implications for the criminal justice system and treatment providers would be. I know, kind of a big question, but there it is.
Well, I think there's really no doubt anymore that the individuals with these traits, sociopathic or psychopathic traits, that they do present as a class of individuals that are high risk. So many studies have shown that if you have high levels of these traits, you are a high risk to reoffend generally, but also particularly violently, compared to somebody who has low levels of these traits. For me, it's really that since we can, and we have now a potential treatment, that we should be trying to affect that treatment for these high-risk individuals to try to eliminate their risk or massively reduce their risk. And that, I think, is transformative for the criminal justice system, because if you have youth that come in that are in this high-risk category, but you can eliminate or vastly reduce the risk that they might end up in the adult system, well, then that's the best possible outcome for everyone. That's the best possible outcome for the child. It's the best possible outcome for their parents and society, and politically, it's the best possible outcome because you can run for office because you reduce the reincarceration rate by 50%. So there's just so much advantage. The short-term problem is implementation, is funding it, is institutional change, is getting everybody on board and starting over, and that's the hardest process that I think needs to take place in order to try to do this, because there's just so much evidence out there that current programming that is implemented in most states is not that effective at changing the trajectories of these ultra high risk kids. Lower risk kids, sure, most things are effective. At the highest risk, this is the only program that I know of that's published that has shown that. And by the way, I completely agree with your earlier sentiments about the MRI data. To me, the MRI is just another tool that we use to help improve our ability to do things. If it helps me predict better, then I want to use it. If it didn't, I wouldn't be using it. If it helps me diagnose better, then I want to use it. And it's definitely a technically challenging thing to learn and think about and understand. once you understand it, and you'll realize that it can have a lot of value for helping to improve the way we care for our patients and the way we take care of those that are in need.
Okay. Well, Dr. Kiehl, this has been really, 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 really a superb Psychcast. I've really learned quite a bit from everything, your research, your insights, your passion in regards to treatment. I think anyone who's followed your work, if they didn't know that, I hope that they glean this from this Psychcast in regards to it's really about, the whole point of this is really about treatment and being able to work with those at times that people really changing the paradigm that they considered folks that they were not able to work with. I really feel strongly that we need to get you in D.C. as much as possible. If I can walk you up to Capitol Hill myself when we have GW like Doctor Day or something like that, I'm serious. I will. I think people need to hear you, and I'm sure they already have, but because this is stuff that's going to get people thinking differently, and hopefully, again, that I think one of the things with the Psychcast over the past couple of episodes, whether it's Dr. Gallagher or others, we're really trying to not help our audience, but work in a way. Work is a strong word. Look at me, I'm sounding all professorial. We want to share with our audience different things that are thought-provoking, that we consider cutting edge, that are going to get us thinking differently, and that in and of itself is going to be a better service. We're going to allow us to serve our patients that much more better. But Dr. Kiehl, sir, one, I'm hoping that maybe we can talk to you again on the Psychcast because I could probably spend like 2 hours talking to you, but you've got so much stuff that we can talk about. I would love to, but I want to leave the final thoughts with you for our audience in regards to your thoughts, anything that you take home points that you want them to have, sir.
Well, thanks. I've really enjoyed the conversation, and I agree. I think I would enjoy talking with you, a lot longer. So thank you very much for that. In terms of audience points, I think the couple of them, which is that these individuals that we work with that have these high-risk people, we really have to have a paradigm shift that illustrates we can treat, we can help manage and improve outcomes for them and for society, and that there should be, I think, I hope that people just realize that there's a lot of optimism around working with this population that has historically been kind of just tossed aside and locked up, and that there really is some great science that's happening and programs that are happening that improve outcomes for everyone. And then it's also economically advantageous to implement state-of-the-art treatment. Many countries, as you already mentioned, are doing this in such a way that with the right politicians and the right motivations, you really can make transformative effects within the systems. And then even though I like to scan everybody, I like to study everyone's brain, but I also like to just emphasize that the brain is just so plastic. I mean, as a neuroscientist, I really feel like we're just still in our infancy of understanding just how plastic and how malleable it is. And even though when we do show brain differences in different individuals, the high or low risk or whatever, that doesn't mean they don't have a capacity for change. And so we learn all the time and are continually, I don't want to say necessarily surprised, but just continually impressed by just how much plasticity there is in the brain for recovery and for change. And so I would just want to leave with those 3 points.
Okay. Well, Dr. Kiehl, thank you so very much for coming on the MDedge Psychcast today, and it's been a pleasure speaking with you.
Pleasure. Thank you so much.
And that's a wrap on episode 85 of the Psychcast by MDedge. I am the voice of MDedge Podcasts, Nick Andrews. You can find more information about the conversation you just heard in the show notes. Okay, it's time for the credits. The Psychcast is hosted by MDedge Psychiatry Editor-in-Chief, Dr. Lorenzo Norris. Our guest this week was Dr. Kent Kiehl. MDedge Psychiatry audio producers are Gina Henderson and Jeff Bauer. MDedge podcasts are produced by Executive Editor Denise Fulton, Executive Editor Kathy Scarbeck, Multimedia Editor Terry Rudd, and Social Media Producer Kyla Clark. I am your audio engineer, audio editor, and the voice of MDedge Podcasts. The show notes are written by Dr. Jacqueline Posada. For all of us here at MDedge, thanks for listening to the Psychcast by MDedge.